Without further ado, we're going to start the academic session. First, our good friend coming from afar, Professor Bancha. Professor Bancha is going to talk about the bucket handle repair techniques. Now, the floor is yours, Professor Bancha.
谢谢你，谢谢大家。I'm Dr. Bancha Chinchuchit from Thammasat University. Today, it's my great honor to be your guest speaker. And thank you, MyTech, and also the Chinese organizing committee for the invitations. So I'm talking about the meniscus bucket handle repair. Okay. So this patient is the 45 years old man. He has a bucket handle tear of the meniscus. So I would like to ask all of you, he's a 45. Will you cut his meniscus, meniscectomy, or will you save it? If you want to cut it, just raise up your hand. Okay. So if you want to save it, please raise up your hand. Okay. So yeah, thank you. So I think in the past we did a lot of meniscectomy in this kind of patients, but now I think the trend is toward the meniscus saving. So we try to save the meniscus, especially if the patient have the bucket handle tear of the meniscus, because the result of bucket handle is pretty good. Even the patient come to see you very late. So the bucket handle tear is about 10% of the overall meniscus tear. So medial side is more common than lateral side. It's about 3 times more common. And 45% combined with the ACL injury. Challenging procedure. So you need to consider 4 factors. Number 1, the tissue qualities. So how about the tissue quality? Is it good or not? Is it chronic or not? Number 2 is the meniscus reduction. Sometimes it's not easy to reduce this kind of meniscus. And tissue stimulation. How to make a tissue stimulation. And lastly is the secure fixation. How to make it secure and stable enough for the healing. So how to perform anatomic and secure fixation for the meniscus repair. So first, I think important is that you need to have a good positioning. So the patient position is quite important. You need the enough space to work. So you can go 360 around the joint. But sometimes you need to go to the back. Sometimes you need to go to the lateral side, medial side. So I prefer this position. So I break the table and drop the leg down. Okay, you put the pause on the lateral side for valgus, and you can do easily the figure 4 if you want to access to the lateral meniscus. Okay, so that is my patient positioning. So another point is that if you have the too tight, very tight joint, I recommend you to make a magic point release. So we should have enough room to work, especially on the medial side, it's very tight. So I propose this technique we call the magic point release. It's very easy. You draw the line from the posterior cortex of the tibia, okay? And then you connect to the adductor tubercle. It's about 1.2 centimeter from the joint. Okay, you touch this point with needle number 18, you can hear the pop sound. Then the joint will open suddenly. Okay, look again, right? This patient, if you touch the right point, it will pop like this. You see? It's pop and open the joint suddenly. Okay, so that's very effective when you want to reduce the difficult meniscus or when you want to repair the meniscus. If you have very tight space, you cannot do that. Okay, and sometimes you can damage the cartilage. Okay, so 3 steps that you need to do when you do the meniscus reduction. Number 1 is to do the gentle reduction. If you cannot reduce it, don't hesitate to make a magic point release. Okay, number 2, if there's a lot of scar tissue, you need to do some scar tissue release. And I always start with the inside out reduction suture. Okay, and also I always start from the front first, like you cross the zip. I will tell you later. And this is a tissue biologic augmentations. So you need to stimulate the tissue because meniscus vascularity is really poor. So I myself prefer this technique. This is trephination. I use the KY number 2 and do the trephination as much as you can. Okay, and you can do some rasping using the diamond rasp. You can use the synovial abrasion, PRP injection, microfracture, or fibrin cut. Okay, but I think this trephination works really well for me. Okay, use the KY number 2. Okay, and the repair technique. So you can do like inside out, outside in, or inside, right? Like I show you, this is outside in. It's good for the anterior part. Inside out, especially the back end handle, I always use the inside out to reduce the meniscus. And all inside, we prefer to use it for the posterior compartment. And on the medial side, be careful when you tie the suture on the capsule. You should beware of the saphenous nerve and also the vein. So this is the simple diagram, the zone-specific technique for the meniscus repair. Okay, outside in for the front, inside out for the body, and all inside for the posterior part. So this is the technique. You need to do it like you close the zip, right? Like this. So you should start from the front, because if you start from the middle, sometimes you may have the anatomic mismatch. So always start from the rim, your first stage should be from the front, okay, and then you follow like that. So you have anatomic reduction. We call the closing the zip technique, okay. And in chronic deformed meniscus, we prefer to use the Mason-Allen technique like this, because this can compress and flatten the deformed meniscus. You see that? This meniscus is very round because it's a chronic bucket handle. Using Mason-Allen, you can increase the surface contact and you can flatten the deformed meniscus to make it like wedge shape again. Okay? I report this technique in the articles. And don't forget to repair the undersurface too, because if you have not enough space, you always repair the upper surface. If you don't repair the undersurface, there will be a gap underneath, or the meniscus can be flipped, okay, upward like eversion. So don't forget to repair the undersurface to make a circumferential repair of the meniscus. Okay, and then we repair the posterior horn of meniscus using the on-site technique. This is the bucket handle together with the radial tear. Okay, so in radial tear, you make sure that you have no gap. This is the new true span for MyTech, right? It's a very easy and very low profile to perform the radial repair for the posterior horn of the meniscus, right? And careful, if you have the radial tear, you should not have gap between the meniscus, okay? Because the healing is really delayed comparing to the longitudinal tear. So now we're talking about the on-site technique using the true span. So this one is the new one just launched for MyTech. Yeah, this new design has so many new benefits. First is low profile. The needle is very small, and also less tissue trauma. And you have the variable angles, 0, 12, and 24 degree. The anchor is peak or absorbable PLGA and partially absorbed autocord, right? It's very robust, and you have the rigid needle while assessing hard to reach the location, and very simplified. You have only one trigger, okay, so no reloading step required. Okay, very easy to use it. Okay, I show you how to use it later. This is the first step. You adjust the stop position as needed, right? So the default depth is 18 millimeters. Yeah, it depends on the locations of your meniscus repair. Okay, the second step is to insert device into the joint using the half pipe or malleable graft retractor. Okay, and the next step, the third step, is to penetrate tissue in desired location. Press depth stop against tissue and pull trigger until click is heard. Okay, and the fourth step is fully release trigger and remove device from tissue. Reposition and penetrate tissue in desired location for second implant. 6 to 9 millimeter away from the first implant. Okay, and the fifth step is to pull trigger until click is heard to deploy the second implant. Release trigger and remove entire device. Okay, and the last step, this is easy. You can just pull one limb. Okay, previously you need to slowly adjust the tension one by one, but this one is easy. Just pull one limb. Okay, and then cut the tail later. Careful when you penetrate to the posterolateral capsule, okay, of the lateral meniscus. On the medial side is very safe. If you look from the diagram, you have no chance to injure the vessels. The vessel is a bit close to lateral side. Okay, so from this diagram, you can see that the location of the artery is about 37 millimeter from the posterior horn meniscus. Okay, so careful when you're repairing in this area. So this area from the study, this is another study from Dr. Ng Wai Ming and Dr. Teo from Malaysia. They found that 5 to 10 millimeter from the root, this area is very risky, so you can damage the vessels. Okay, so careful when you're repairing the meniscus. 5 to 10 millimeter from the lateral root, you can damage, you can injure the vessels. So now I show you the cases. So first one is the female. Okay, she has the meniscus tear and tendon of the medial joint line. Okay, so McBurney test positive. X-ray look normal, but she has so much pain on the medial side. You can see that she has a radial tear of the meniscus. She starts to have some cartilage damage. I use a magic point release because it's not easy to repair the meniscus. See, after we do the magic point release, you can see the meniscus better. Okay, and then we do the side-to-side repair of the meniscus. Right, I use the mid-medial portal. Okay, and then we make another portal. This is very useful when you try to repair the posterior on the meniscus. Right, so now you have the 3 portals. So use the shaver really little, because if you shave it too much, you create a gap in the posterior horn of the meniscus. So I used a basket punch, slowly remove the unstable part, right, and perform the trephination. We first start with the suture hook to repair the peripheral part of the meniscus. Okay, I prefer to use the autocut because this is partial absorbable suture, right? So then we repair using the autocut at the first one, and then we use the autocut for the second one using the suture hook, and the last one we use the true span, right? This is very low profile, so you can use the side-to-side repair using the true span, right? So after you put the needle in, this is 12 degree. Most of my case I prefer 12 degree. You see, it's very low profile, and you just use one trigger, the lead trigger. You put in first, and then you push the trigger, and then second shot and push the trigger, right? Very simple, very easy. Okay, and then you slowly tension and make it side to side like this. Okay, so this is a final repair of the radial tear of the meniscus, right? She's very happy after surgery. And this is another patient. She had the meniscus tear. This is longitudinal tear, so it's on the lateral side. So very careful when we repair the meniscus in this area. I told you it's about 1 centimeter from the root. So this area you have to be very careful, okay, because it's very close to the vessels, right? So this is a lateral repair. So in some bucket handle, they have the lamp lesion also, like this patient. The torn side is very close to posterior. Also, I start my bucket handle by repairing the lamp lesion first. Okay, and after that, I go to the front to repair the meniscus using the inside out and all inside, right? So that is the bucket handle that extend to the lamp lesions. So this is the patient, 28 years old. He's a soldier. So has a chronic bucket handle tear. You see, it's very difficult to reduce. Has a flexion contracture. It's on the lateral meniscus also. I cannot release the lateral side. I may ask you how to release, how to open the lateral space. I cannot release the LCL or popliteus because I'm afraid of the instability. So this patient, I cannot reduce the meniscus back because it's chronic bucket handle lock. So I use the inside out first to reduce my meniscus as I can, and then I use the all inside meniscus repair to reduce the meniscus back. Okay. This is 1 year after surgery. He's doing well, and his meniscus healing is really nice. Okay, so he's happy with the result. The second patient, this is a medial side. I think the medial side is easier than lateral side. This is a chronic bucket handle tear, 32 years old. He has a double PCL sign. These bucket handles, first we make a trephination, shaving, rasping, reduce the meniscus back. Then we start with the inside out first, okay, from front to back, like you crossing the zip. And then finally, this patient, 6 years after that, the meniscus heal nicely, okay. So this third case, a lateral side. Lateral side is more complicated. This patient have knee dislocation, he has torn ligament, and also has a meniscus root medial side. Lateral side, the meniscus displaced totally. You can see that. When we get in the joint, we cannot see the meniscus. We just see the popliteus tendon, right? And there's a lot of the scar tissues. The patient come to see doctor very late. It's about 2 months after the knee dislocation. So what we have to do is that we need to release the scar tissues. You see that I cannot reduce the meniscus to the capsule. You see that there's a big gap. Even I try to use the inside out first. You see that? Here, you see the gap? Very big gap between the meniscus and the capsule. So you cannot accept this because it will fail. So what you have to do is you switch your camera to the back of the joint using the transeptal technique, and then you release the posterior horn of the meniscus from the capsule. Okay? Don't worry, you need to release that. Okay? After you release that, then your meniscus will be mobile and you can repair it back again. Right? So after the release, okay, then I coming to the front again, right? And then I start with my inside out, like closing the zip technique, like this, okay? So now you can see that there's no gap, okay? Your meniscus is very mobile. You can repair it back to the capsule, and then finally you can repair the posterior horn of the meniscus to the capsule, right? So don't give up. If it's not reducible, you need to do more release, okay? And use the inside out for reduction, okay, and or inside, okay, for the posterior horn. This patient have the chronic bucket handle lock also. He has this is 2 years after the bucket handle lock. You can see that he's a very big meniscus and it's deformed, it's round, very round. It's not like wedge shape anymore. So I did the magic point release. After that, we use the inside out for reduction. You can see that even after the reduction, the meniscus still deformed. It's like a noodle. It's very round, right? And after that, I use the Mason Allen's for him. And this is after the repair. His meniscus healed nicely, and his function is also very good. He has no more flexion contracture, okay, and his motion is getting better. So this patient, I immobilize him in full extension for 4 weeks because his meniscus is very unstable, right? And I let the patient walk for bucket handle, but don't worry, because when the patient walk, the meniscus will be more. But don't let the patient bend the knee too much, not more than 90 degrees, because your meniscus will be torn if you bend too much. But you can let the patient walk for the bucket handles, okay? So this is the last patient. He's a 15 years old, very young boy, has a bucket handle tear of the meniscus. from the football injury. So I repair his meniscus. Okay. So I try my best to fix his meniscus, and after that, his meniscus healed nicely. And this is about 7 months after that. He's doing well, and he back to play again, right? So 2 years after that, he come back to see me again because he meniscus torn again. So I need to get in and do the revision meniscus. Luckily, the tissue quality is good. Okay, so I try my best to fix his meniscus again. Even this is the second surgery. Okay, don't give up. Okay, you repair it. For this time, I add the meson islands to improve the surface contact. See that? So after that, we make a secure fixation, and I delay the rehabilitation. So this is 7 months after surgery. The patient doing well, and he can go back to play the active sports. Okay. So the last situation is the Acl together with the meniscus. I will tell you, please do the femoral tunnel first, because if you do the femoral tunnel later, you fix the meniscus first. When you come back for the femoral tunnel, you need to do deep bending, right? When you do deep bending, your meniscus can be torn. So don't forget, perform the femoral tunnel first, and then medial meniscus, and then tibial tunnel. So for the take-home message, okay, try to save your meniscus. Don't give up. In chronic situation and reduced meniscus, don't hesitate to make a magic point release to improve the exposure. Repair the meniscus like closing the zip, circumferential repair, both upper and under surface, and proper rehabilitation. And always discuss with the patient about the failure, because about 1/3 of bucket handle tear can be torn again, right? And let the patient know that you have a good willing to repair the meniscus, okay? And tell the patient, don't sue you if it fails, because you try your best to save his meniscus. Okay, thank you. 谢谢你们。